question. After 1 minute, we'll begin. There are 2 slides. Once you've read this one, please tell me, I'll move.
Next.
Yes, please. Not too much written, it's just one diagram in the question. All right, so if you have read and understood considering it critical care scenario, please tell me, how would you manage this patient?
Yeah, thank you. I will manage these patients using ABCD of critically ill
Yes.
surgical patients.
Yes.
First, I want to take brief history to ascertain my diagnosis. I want to quickly examine this patient. I want to check the airway is patent. I want to check the breathing. Patient is breathing normally. Check the respiratory rate. Then check the oxygen saturation desired. I want to put patient on the oxygen. I want to set an IV line. If possible, put a central line for this patient to monitor the rehydration status, give IV fluid, and if possible, put patient on supplemental nutrition. I want to check the patient disability, the gastrostomal score, to know if the patient is conscious. At the same time, to check the drugs the patient on, the antibiotics and analgesics.
Good, thank you. Could you please tell me what differential diagnosis would you keep in your mind while reading or considering this scenario?
And we have acute pancreatitis.
Okay.
The differentials could be viscous perforation, could be acute cholecystitis, could be cholangitis.
All right. Can you tell me what might be the causes of acute pancreatitis?
Gallstone.
All right, good.
Chronic alcohol.
Alcoholism.
Drugs like thiazide, like steroid, infection like mumps, coxsackie, typhoid.
Good. Can you tell me what is the pathogenesis which is behind all this condition?
Most common is duct obstruction, which may cause reflux of the bile into the pancreatic duct. There could be direct external injury from infection, from trauma, and from infection, from drug. There could be direct injury, direct injury from trauma to the sinner.
Because of virus, bacteria, or trauma. And anything else?
Yes, there could be protease enzyme release could cause damage to the pancreas.
Can you tell me why would this patient be tachypneic?
Yes, the patient was tachypneic because he could have acute respiratory distress syndrome. There could also be, if there is abdominal distension, this could be splitting the diaphragm. And the patient could also have sympathetic pleural effusion.
Okay. Can you tell me what are the, if you know any criteria on the basis of which you can confirm your diagnosis as acute pancreatitis?
Yes, Ramsey criteria, Balthazar criteria, the UCT scan, and Apache 2.
Please tell me about the Ranson criteria after 48 hours.
Okay, for Ranson criteria after 48 hours, I want to do investigations like okay, I'll come back to that, sorry.
All right, okay. Can you tell me what are the causes of hyperglycemia in patients with acute pancreatitis?
Yes, there could be destruction of the beta islet cells of Langerhans by pancreatic enzymes.
Yes.
And there could also be release of stress hormones like glucagon, epinephrine, and epinephrine and epinephrine.
Very good. All right. Can you tell me what are the enzymes which you test in order to establish your diagnosis as acute pancreatitis?
I want to do serum amylase and serum lipase.
Very good. Okay, can you tell me two conditions in which a patient has acute pancreatitis, but serum amylase levels turn out to be normal?
If the sample is taken too early, within 6 hours, or
Yes.
and if it's taken too late, after 48 hours.
All right, good. Right. Can you tell me, which radiological investigation you will do first and why?
I can do usually a computer tomography scan of the abdomen,
Yes.
which will show the presence of phlegmon or pancreatic necrosis or fat stranding or yeah.
What are the
I can also do
complications?
ultrasound.
Yes, good. What are the complications that you could expect if you do not get to manage the patient with acute pancreatitis on time?
Patients will have pancreatic cirrhosis. They could develop disseminated intravascular coagulopathy. They could develop um, uh, GI bleeding,
Yes.
paralytic ileus. They could have acute renal failure, acute respiratory distress syndrome. They could have shock. They could
Yes.
have multiple organ failure. They could even lead to death.
All right. Please tell me, what do you understand by the acute respiratory distress syndrome, ARDS?
Yes, acute respiratory distress syndrome is okay. I'll come back to that as well.
All right. Please tell me, how would you take care of the new patient's nutritional status?
I want to start patient on total parenteral nutrition. Where it's possible, I can do enteral feeding using nasojejunal route.
All right. Right. Patient normally present with too much pain when they are diagnosed with acute pancreatitis. How would you take care of pain of the patient?
Yes, take care of the pain using the WHO pain ladder, starting with non-opioids, the acetaminophen and ibuprofen. And if there's no improvement, I can go with mild opioid, codeine, and if there's no improvement, I can go into a more potent opioid like petidine, which is more potent for acute pancreatitis patients. If I have my way, I want to avoid NSAIDs and morphine as much as possible.
How would you know if you've given paracetamol to the patient and patient presents with liver injury? How would you make sure that patient has not suffered from paracetamol overdose? How would you rule it out?
Yeah. Sorry, let me get the question again.
Yes, you've given pain analgesics to the patient for pain management, pain control. And after a while, patient has presented with deranged liver function test. How would you
Yes,
confirm that patient has not suffered from paracetamol overdose?
Okay. I want to check the drug chart to know the amount of paracetamol that has been given. Usually, the toxic metabolite is N-acetyl
NAPQI, yes.
N-acetyl
Yes.
P-benzoquinone imine, which
Yes.
is toxic to the liver, and usually this is usually metabolized or neutralized by beta-thione. So if we have excess of the paracetamol that cannot be neutralized by the available beta-thione, this will actually cause injury and cause the range function of the liver.
All right. After Bell has gone, but last question, please. After 4 to 5 weeks have gone and patient's blood labs have returned and serum amylase is still raised, this investigation would give rise to a new diagnosis in your mind. Which one?
That's pancreatic pseudocyst.
A pseudocyst. Yes. Good. Right. Good. Good. Thank you.
Yeah, can I go back to the Ramsey's call? Yeah, I think I should be able to phantom it out now.
Yes.
Yeah, you mentioned for 48 hours. I know I want to do calcium, serum calcium, which is likely to be less than 2 cm. Then to do ultrasound to look out for fluid sequestration, likely more than 6 liters. Then hemolytic concentrations likely fall by 10%. Then oxygen concentration usually less than 60 millimeters of mercury.
Yes, and
Then
nitrogen.
urea is likely greater than 5 millimole per yes.
Very
Urea
good.
is greater than 5 millimole per liter.
Very good. Yes. Base deficit.
Base deficit is greater than 4.
Yes, good. Right. Thank you.
Thank you, ma'am.